Welcome to today's Explainer. We're jumping right in today because I am absolutely thrilled to walk you through a truly massive shift happening in American healthcare policy. Mark your calendars for July 5th, 2026, because on that day, traditional Medicare is undergoing a transformation that will fundamentally alter how chronic care is delivered and, more importantly, how it's paid for. We're going to demystify the CMS ACCESS model today, and I promise you, whether you're a healthcare professional, an innovator, or honestly just someone fascinated by huge systemic shifts, you're going to find this incredibly insightful.
Right off the bat, you need to know that for literally the first time ever, Medicare is transitioning from buying clinical activity to buying actual clinical results. Take a second to really think about that. We're going to treat this explainer like a major business case study. We aren't just looking at boring medical billing. We're looking at a total realignment of incentives. For the first time, payment is going to be directly tied to a patient actually getting better.
All right, let's look at the roadmap for today. We'll cover 1, the Medicare payment shift, 2, measuring clinical results, 3, evidence across clinical tracks, and 4, the demographics challenge.
Section 1, the Medicare payment shift and moving away from fee-for-service. To really grasp this new model, we first have to recognize the fundamental flaw of our current system. Right now, care is paid for by defined activities, totally divorced from the actual health outcomes of those activities.
Under that old way of fee-for-service, you get paid for a visit, a device, or, a 20-minute increment of remote monitoring. But think about modern digital health tools, things like continuous coaching, asynchronous check-ins, algorithm-driven care. They never fit neatly into those clunky old fee-for-service codes. So CMS is launching the 10-year ACCESS model to fix this massive gap. They're introducing the new way, which is an outcome-aligned payment. It's a recurring per-patient payment for managing a condition, but, and here's the kicker, full payment is strictly contingent on measurable improvement relative to that specific patient's own starting baseline.
To really anchor the stakes here, we have to look at some hard numbers. Over in the commercial employer market, digital musculoskeletal, or MSK programs, have historically commanded roughly $1,000 or more per engaged user annually. The new ACCESS model, it pays just $180 all in. That is an incredibly thin margin. And actually, these flat, low per-patient payments are completely intentional. They are forcing providers to scale efficiently and basically figure out how to deliver an effective care model at a radically lower price point.
Section 2, measuring clinical results and the actual mechanics of the policy. This right here is the core focus of our explainer today. If Medicare is paying for results, we really need to look under the hood at exactly how the ACCESS model measures that clinical success.
50%. That is a huge number, and here's why it matters so much. CMS pays providers monthly, sure, but they hold back a staggering 50% of the Medicare share until the very end of the reporting period. If you miss your outcome targets, that withheld half, it's completely gone. It's totally at risk. Providers now have undeniable serious skin in the game.
So how exactly is this success measured? Well, let's walk through the strict timeline they've set up. Step 1 is the baseline measurement. They use a validated patient-reported outcome measured on day 1. Step 2 is the 12-month care period where the patient receives continuous management. And finally, Step 3 is reconciliation. At the end of those 12 months, the outcomes are measured again through CMS application programming interfaces, and then they're compared directly against that patient's original baseline to see if real, tangible improvement was actually achieved.
And all of this builds into a crucial metric called the Outcome Attainment Threshold. For 2026 and 2027, the rule dictates that at least 50% of a care organization's aligned beneficiaries have to meet all their required targets to earn the full payment. Think of this like a giant population-wide report card. Your payment relies on aggregate success. While the model forgives a few non-responders, it severely punishes weak engagement at scale. Simply put, if your population as a whole doesn't get better, you lose that 50% withhold.
Now, to make this whole system work, CMS built in 2 fascinating operational rules. First up is exclusivity. During an active care period, the ACCESS payment completely replaces fee-for-service revenue for that specific condition. But CMS also created what we can call a co-management flywheel. Referring primary care physicians actually get a brand new co-management payment for documented review and coordination. This is huge because it gives traditional doctors a direct financial reason to send patients into the model and, more importantly, stay engaged in the loop.
Section 3, evidence across clinical tracks, or what actually moves the needle. We know the financial rules now, but what works clinically? Let's explore what the Peterson Health Technology Institute, or PHTI, evidence says actually achieves these strict results across different conditions.
The absolute crucial point here is that success depends heavily on how the intervention is structured. For early cardio-kidney metabolic disease like hypertension, the key is the speed of the feedback loop. You need virtual care teams with actual medication authority. Just passively monitoring them isn't going to cut it. For established disease like diabetes, it's a targeting problem. Remote monitoring only works well when it's aimed at patients with the highest starting metrics. For MSK, triage and physical therapist guidance are critical. App-based exercise alone without a clinician? That is the weakest evidence. And for behavioral health like depression and anxiety, clinician-guided cognitive behavioral therapy roughly doubles the effect sizes compared to just using unguided self-serve apps.
Section 4, the demographics challenge, reaching the Medicare population. Now, this is the ultimate reality check for this entire policy.
We really have to ask the elephant in the room question. Will a 65-year-old actually use this technology? Nearly all the flagship digital health evidence we have was generated in younger commercial populations. The demographic data here is pretty stark. Adults 65 and older are roughly a third less likely to use health apps than younger adults. On top of that, app-based chronic disease interventions across the board suffer a massive 43% pool dropout rate.
But here is the fascinating, evidence-backed truth of the matter. Age raises the activation energy, sure, but it absolutely does not blunt the treatment effect. When older adults actually do engage, they see incredible results. For instance, in a virtual MSK program studied specifically in adults 65 and older, a massive 77.8% of patients achieved meaningful pain relief. The biological response is absolutely there. The central issue is simply getting them to start and stay with the program.
So how do we fix it? The source material points to 3 evidence-backed solutions to overcome this barrier. First, human onboarding. Having a real, live human help set up the program in those first 48 hours drastically increases adoption. Second, coaching over self-service content. Coached patients complete significantly more sessions and achieve better pain relief than self-directed ones. And third, AI-dosed human touchpoints. This means using reinforcement learning AI to smartly allocate a human therapist's time, deciding who needs a real-time call and who just needs an automated check-in. It keeps engagement high without blowing up your delivery costs.
Which brings us to this incredibly powerful summary from the source material. The differentiator is never the app. It is the delivery model wrapped around it. Under the ACCESS model, the organizations that win are going to be the ones that treat patient enrollment, onboarding, and adherence as their main product, viewing the clinical content itself as just a commodity.
As we wrap up, I want to leave you with a provocative question to ponder. That incredibly thin $180 pay rate is going to pull organizations heavily toward cheap automation. Yet, as we just saw, the clinical evidence definitively demands a human touch to keep older patients engaged. So, as this outcomes-based contracting scales nationally, will the ACCESS model truly reward demonstrated clinical value, or will highly effective care models just get crowded out by the most easily automated ones? It's a massive tension, and it's one that will absolutely define the next decade of Medicare. Thank you so much for joining me for this explainer. I hope this helped you grasp both the mechanics and the sheer magnitude of this policy shift.